Thank you very much. Thank you for inviting me back. And I'd like to thank the coordinators of this, actually a very informative discussion. Now, there's been talk about all dementias before, so what I like to do is maybe go through a little bit more in dementia and what's it about and what's new, and then bring in on some of our studies that we do at the Dent Institute. So, disclosures. The only thing that's interesting is that I have done research with Charlotte's Web looking at pharmacokinetics, but this discussion is not about that. Rest of it is work I do at the Dent Institute. I have about 100 ongoing studies right now in the field of neurology and pain. And this is our institute in Buffalo, New York. We're proud of it. It's a private institute. Hence, we can do a lot of things at a private institute that academic institutes are a little bit nervous about doing. It's the largest in the country. We see about 320,000 patients per year, which is about 1,400 patients every day in the field of neurology. And this is the cancer hospital. I'm the chief of neuro-oncology for the last 25 years. This is an institute that I developed about 7 years ago in Europe, specifically Budapest, Hungary, with the idea that I'm going to do cannabis research in Hungary. We can't do it in America, so let's go to Europe. I'm of Hungarian descent. But unfortunately, it didn't work out because the government is rather restrictive, and Europe has been a disappointment in general when it comes to cannabis research, working out of countries like Switzerland and Portugal, thinking that we could do research, but it hasn't panned out as much as I would like to have. We do research in other things there. So at the institute that I work at the Dent, this is our numbers. The number actually is 13,500 patients who are in a medical cannabis program in New York State. As I mentioned, we're in Buffalo, and New York State has rather rigid precautions on how to use cannabis. So this data that we have on about 13,500, as you can see, most patients have cancer, chronic pain, then cancer and neuropathies, MS. And today I'm going to also be talking about dementia. And what is dementia? You had some discussions. We all have definitions. But as a neurologist, my feeling is that the first thing you have to see about dementia is reversible dementias. So we have somebody with cognitive side issues at any age. We have to look for reversible dementias, which are potentially treatable. Here's a list of them. And this is called pseudo-depression of dementia, when depression is a common finding in patients with cognitive decline, especially stress-related disorders, hydrocephalus, alcohol, space-occupying lesions. Being a brain tumor specialist, I'm very astute about these issues, metabolic diseases, and I go down that list. So these are the reversible dementias. After we rule that out, then we say, well, what is dementia? It's a global sudden onset of decline of cognitive functions, resulting in impaired ability to perform daily activity. That's dementia. MCI, and there's about 6 million people in the United States with dementia. 12 million have mild cognitive impairment, which is some cognitive effects, but they're still driving, going to work, but they're coming up to you and say, hey, I have something's not right. And we call those individuals MCI. But the majority of dementias, 80%, is due to Alzheimer's pathology. Alois Alzheimer was actually a psychiatrist, pathologist in Bavaria. He wrote the first article on a 60-year-old called presenile dementia with pathologic confirmation. So, interesting history. I'm not going to bore you with the whole thing because I have to be on time, but dementia is currently the 7th leading cause of death in the United States. 2019, dementia cost about $1.3 trillion. Approximately 50% of those costs are attributable to informal carers, so people who are taking care of that. With supervision. It's really a devastating disease. Everybody here in the audience knows somebody, has somebody who's going through dementia. It is one of the most saddening things you can see. And everybody in your age, my age, also has the fear, what's going to happen in 10 years. So women are disproportionately affected by dementia, just not only directly, but indirectly, because being caretakers historically, that's been a major issue. So when we talk about types of dementias, What's interesting, not many people know this, that 60-70% of dementia is actually Alzheimer's. By pathology, by presentation, by imaging, by neuropsychometric testing. But what one doesn't know, by the age of 75, even if you're normal, 35 to 40% of people have pathologic changes of senile plaques, of neurofibrillary tangles in the brain, even though you may not have manifestations of that disease. So there's frontotemporal dementia. We used to call that Pick's disease for the older physicians. Lewy body, vascular dementia, and mixed dementia. So I'm also a neuroradiologist, so I do a lot of research and imaging of neurological diseases. Here's Alzheimer's disease, where classically you'll have parietal lobe and temporal lobe decrease in fluorodeoxyglucose. So Alzheimer's really is medial, temporal, hippocampal, and parietal lobe atrophy. And here's SPECT scan, which is a poor man's PET scan. And then Alzheimer's disease, now we have amyloid PET. You can see the amyloid accumulation on these cases. This is normal, this is abnormal. So now we do have studies in vivo, pre-mortem, to look at this. And this is the classic progressive aphasia, similar to what a movie star has right now, suffering from aphasic dementia, where you have left dominant temporal lobe atrophy compared to the right, and now you can see the atrophy in the frontal lobe. So there's different variations of this disease, and this is vascular disease, just to show you what multi-infarct dementia due to multiple strokes could do. It's a subcortical dementia, but still a dementia. You see the strokes, which are on FLAIR studies, quite bright. So the continuum of Alzheimer's disease, preclinical, the pathology is present, but there's no clinical symptoms. So in 70, 80-year-olds, if you, for whatever reason they pass away from a motor vehicle accident, you'll see pathology consistent with Alzheimer's disease that's preclinical. MCI due to Alzheimer's disease. So these are objective cognitive deficit, no meaningful compromise, and then you have mild, moderate, and severe dementias. Once you're severe, even moderate, then unfortunately there's not many things we can do except palliative care. Unfortunately, as you know, nursing homes tend to have a tendency to overutilize very aggressive medications, which increases the morbidity and mortality of these elderly patients by putting them on major tranquilizers such as Seroquel, which is common practice in nursing home, agitated Seroquel. Put them on Seroquel, sedated, aspiration pneumonia, they die. It's a little bit like a hospice care where they're terminal, felt to be terminal. The average lifespan of an Alzheimer's patient is about 4 to 8 years. Early also MCI mild dementia, 4.6, that's closer to 6 million. MCI is about 12 million. This is the real problem. I do practice medicine in Europe, and they have the same numbers, same issues, where Alzheimer's disease is becoming probably the most devastating disease in the next 20 years. And for that reason, research has been focused on it. And this is what we're looking at, amyloid beta and neurofibrillary tangles that you see here, distinct in certain locations. Yes, you could have that in normal people, but it really is the frequency and the location, hippocampal, amygdala, mesial temporal lobe, cingulate gyrus. These are the most common places. And currently, amyloid beta and tau and biomarkers that you can check for in the CSF, so for patients. Now, treatments, I'm going to just give this one slide because people heard that Biogen came out with this drug. It was approved. A lot of people were quite upset. It cost about $40,000 a year. And the benefits of the drug were really marginal at best. And the complication rate was about 35%, where they had area edema and they had also microhemorrhages. So this drug was taken off by Biogen, by the way, after criticism. And now this drug has been approved. A lot of other drugs we are studying at our institute for the treatment of a disease which up to now had no treatment. So how can cannabis be potential treatment? Well, this is a study we did several years ago, just looking at patients over the age from 75 to 103. We did about 141 patients. We gave them, under the New York State Medical Marijuana Program, we gave them either, the 20-to-1 or Chemovar 1, 2, or 3. And then at the end of the day, we looked at this patient population. This got a lot of media exposure all around the world because they highlighted as grandma, grandpa, do well on pot, something like this, some kind of catchy phrase. But 69% of patients reported symptomatic relief, chronic pain, neuropathy. I'm not saying anything new. Dr. Sulak really summarized it well about the positive effects in regard to pain and anxiety. 71 or 34% reported side effects, but those side effects are really minimal, and few of those patients came off study because of side effects. And so this was a very positive looking at this elderly geriatric population, which by definition already has neurofibrillary tangles, already has beta amyloid plaques pathologically. And what's most important is this number down here, 32% of patients really came off that. Now, my practice is purely medical marijuana. I don't do recreational marijuana, even though it's proved in New York State. I have the 80-year-old with rheumatoid arthritis who does not want to get high. They just want to feel better. They want quality of life. I think everybody understands that perception here in this group. So treatment option, well, why is cannabis so interesting? Well, it's anti-inflammatory, it's neuroprotective, antioxidant, and pain relief. I was thinking of going into the basic biology or chemistry. You've had that talk already today several times and yesterday. But post-mortem studies also shown that patients who suffer from Alzheimer's disease had low levels of anandamide, which is very interesting, and the endocannabinoid deficiency syndrome described by Ethan Russo and lecturers today is very interesting because we never thought of Alzheimer's disease having low anandamide levels. Maybe it's a deficiency syndrome. I do lecture that a lot of neurological disorders are deficiency syndromes. Let me give you an example. Depression, anxiety, deficiency norepinephrine and serotonin. Parkinson's disease is a deficiency in dopamine. Alzheimer's disease is a deficiency in acetylcholine. So there are deficiency syndromes that we treat routinely, and never thought that anandamide may be an issue here. These are some of the advantages of cannabinoids, terpenes. We do forget about terpenes. We talk about the entourage effect, but terpenes are very important in many ways because, for example, the most common terpene, myrcene, is a very sedating drug. Just wrote an article with Pacific Research Institute about the use of purely myrcene in drivers. And we blame THC for people who drive 5 miles an hour. And the reality is the study showed that myrcene is far more sedating statistically in drivers with effect at driving simulators. That's what we use to patient. And that was recently published just on myrcene. So we do have to strongly consider terpenes as an issue here. But for patients with migraine who are agitated, THC, CBD, obviously dose-dependent, anxiety, psychosis, I do agree that I do use THC in patients with schizophrenia. You have to dose, it's dose-dependent. I don't think it's a contraindication. But CBD more often in psychosis. Insomnia, I would put myrcene up there. Anorexia. One of the side effects in dementia patients is they gain weight. In my mind, that's good because patients with chronic dementia lose weight. Aggression, depression, pain, memory, and all these things, you see these advantages of different compounds. This is the article, it's outside. I'm not going to go through this. This is a retrospective study. We actually saw 180 some patients, and then we looked at different variations of potential side effects as well things that may help their quality of life. At the end of the day, out of 180 some patients, we found 116 meeting the criteria. 65% of patients reported symptomatic improved pain and sleep. 50% reported which resolved. We really didn't have a person come off study. Reductions in traditional pharmaceutical. This was very important because a lot of these patients came off drugs. They may have been major tranquilizers, risperidol, Seroquel for agitation. Those patients saw a slower rate of decline. So we did not see any changes at 5 or 6 months between the middle mental state examination, mini mental test, or Montreal test for memory. We did not see any deterioration of the cognition. Demographics, this is the demographics, 57% were female, 43% male. And these are the report improvement, as you can tell. Pain, sleep, quality of life issues, Undoubtedly, the family members felt there was significant improvement. Reported adverse effects, increased appetite, I have no problem with that. And then cognitive difficulty, which was really vague. It was really not cognitive difficulty, but most patients did not come off study. So decreased appetite, report side effects, fatigue. And then one asked, what did we use? We used Chemovar type 1 in 44% of patients and Chemovar type 2 in 37% of patients. And the average dose is up here, THC 8.5, CBD 7.8 milligrams. Now, I think this is the most important thing, especially in today's world, especially in my world, which is hospital-based evaluations, ER evaluations of fentanyl overdose, which unfortunately often do not reach the hospital. And we noticed that in reduction of opiate, in my chronic migraine population, which we published, 50% had a significant, at least 50% or complete reduction in opioids. Trigeminal neuralgia, if you know what that is, that's a very painful syndrome in the geriatric population. 43% came off their opioids, or 50% decrease. Elderly was 32%. Parkinson's was 48%. MS was 38%. Concussion, post-traumatic head injury, 38%. And then this is a statistic in regard to Caucasians was African American. So the total number when added, 163 over 490. Not everybody comes off that, but it's a very enlightening number, especially in today's world with over 120,000 patients a year dying from fentanyl overdose. So whether the tinctures, capsules, vapes maintain a value, ratio 1 to 121, the patients report improvement independent on the ratio, 39 in our study anyhow. The reported side effects of patients were minimal with fatigue. Side effects largely subsided, no statistical significant in cognitive deterioration, which is very important. And the results from the study show that medical cannabis is well tolerated. These are concerns that regarding the cognitive impacts and use of Medicare's treatment option. So right now, I have not inadequate science to say that medical marijuana or cannabis is effective in the progression of the underlying disease. But beta amyloid, neurofibrillary tangles, there's not enough studies to confirm that. As say, I published an article on Parkinson's disease. I have one out there on ALS also. That's just enough. But when it comes to quality of life, unequivocally, it's been helpful. While cannabis may offer symptomatic relief and comorbidities of Alzheimer's, it is not a substitute for evidence-based medical treatment. Now, I should qualify that because one could critique the evidence-based treatment. Just before I got on stage, I got a call about an Alzheimer patient who is having problems with the use of two of the drugs that I use often for the treatment of Alzheimer's, which in this case was Aricept and Namenda. And we are acetylcholine esterase inhibitors to increase the acetylcholine in the brain. And they just don't tolerate it, and I'm not sure what the efficacy is, but since the last 15 years, that's the only drugs we were able to give the Alzheimer patients. And now that we have these new monoclonal antibodies, the world may change, but still, any patient presenting you with moderate to severe dementia, it's just too late. The only way to treat these individuals is catch them early, probably in the MCI stage, confirm that by spinal taps, PET scanning, preferably amyloid PET scanning, and also neuropsychometric testing. It's premature to conclude that cannabis is a better treatment option for Alzheimer's disease compared to the medication. But like I said, in nursing home, if you want to help somebody along in their course of life, you put them on heavy tranquilizers. Because after you put them on heavy tranquilizers, their morbidity and mortality will increase. I just want to, real fast, I have chronic traumatic injury. I also was asked by the NFL to give them a talk about CTE and the use of cannabis, which was interesting. This is a few years before they changed the rules. Caused by repeated severe concussions, a lot of the media is focused on this. A lot of these pro athletes have committed suicide, offered their brain for evaluation by a well-known pathologist in Boston, damage to brain cells, military personnel. And it's called chronic traumatic encephalopathies and advancing neurodegenerative disorder that is abundance of hyperphosphorylated tau protein, which is similar to Alzheimer's disease. In fact, this is just a diagram of the difference. There are tauopathies, Alzheimer's, cortical basal degeneration, frontotemporal dementia, Pick's disease, CT, and PSP, which is also called Richardson-Steele-Olszewski syndrome. And neuroprotection, and this is, again, I didn't get into the basics, but THC does reduce the presynaptic release of glutamate, which is excitatory, which happens after traumatic brain injury, reduce post-traumatic calcified influx in the MMDR, regulates signal pathways, and CBD inhibits the breakdown of our endocannabinoid-independent receptors, regulate intracellular calcium through the mitochondria, and anti-inflammatory, and so on. So there are some theories why we should be able to use THC, CBD, and in patients with degenerative neurological disease, not just Alzheimer's disease, but Parkinson's disease, ALS, post-traumatic brain injury, and CTE. Neuroprotective cannabinoids, modulation of intracranial calcium levels, radical oxygen species, modulation of apoptosis, stabilizing mitochondrial membranes. And I go through all this. All this was discussed in the previous meetings. This is just a slide summarizing these effects. Now, one of the things I've done is as a physician who lived in the world of academic medicine, being a professor for many years in neurology and oncology, I took it upon myself in a world of, because the problem we have is not Dr. Russo, Dr. Serlach, Dr. Goldstein, that's not the problem. They're the gods of cannabis research and science and treatment of human beings. The problem is our medical societies, who are very conservative, and in general, if you look at each medical society you may belong with, the exception may be the nurses, who are really forward-thinking individuals and think out of the box. It's, yeah, you could. But the reality is, our societies are so conservative that on their website they say, you know what, it should deschedule it. We agree with that. We think there's potential, but you shouldn't use it. It always ends up, you should not be using it. And we use it every day. Because not enough science, not enough randomized studies, even though we know about the politics and the history of cannabis research. So what I've done is, I've lobbied in Washington, go down there every year, talk to Schumer, talk to Pelosi, tell them that why do we need to have cannabis in our medical armamentarium to treat human beings and suffering. And it's always a difficult job. You waste 3 days down in Washington. You got to get dressed up like an idiot with a green bow tie, because that's neurology, green bow ties, I don't know why, and walk around in a pseudo tuxedo talking to politicians who give you a nanosecond. So this is very important, because it's really we have to change medicine, not here, not with us, but at the medical societies. Because once they're on board, and we all know why they're upset. They're upset because people in Colorado, patients and children, changed the politics of cannabis by bypassing the medical societies. They went right to the politicians. Politicians saw an obvious benefit to do something, and all of a sudden the medical society says, hey, wait a minute, back off, not enough randomized studies, and so on and so on. So this is a real problem, and that's why when I got involved, I tried to legitimize the process, which was not also difficult. Now this is I mentioned that I don't have any issues in regard to my talk. This is the only one I just put in at the last moment. And I had a discussion with Dr. Russo. And the question here is, does the pharmacokinetics of a new drug with nanotechnology help in the absorption and Cmax, Tmax? So what I plan to do is look at this new crossover delivery system and see if it helps our patients in different neurological disorders. Specifically, I'm going to look at migraine for this. And then I'd like to thank you, and I'd also like to thank you, my team. I'm 5 minutes early because I was 10 minutes late in the start. So thank you very much, and for allowing me to come back here today. I wanted to say that you were supposed to play some song about gods, and I noticed that there's 3 gods here that I know well. Ethan Russo is Zeus. the God of gods. Bonnie Goldstein is Athena, the God of wisdom. Now, Sirlak, Dustin, is Aphrodite. He has 4 kids. Do not shake his hand, okay? He has 4 beautiful children. Thank you very much for allowing me to be here today.